again falls to minimum level, it is the diastolic pressure. So this is how the oscillatory method uses its blood pressure monitoring. Next, we should discuss the disadvantages of automated blood pressure. These are simple. Inaccuracy of with systolic pressure less than 60 mm of mercury. Inaccurate if the wrong size of cuff is used. May be inaccurate in obese patients. Discomfort in awake patients. Skin and nerve damage in prolonged use. So we go for invasive blood pressure monitoring. Delay in injecting drugs and reaching the circulation, not usually in operation theaters. We have a blood pressure cuff on one arm, and also IV line and drugs are going through that arm. So delay in injecting drugs would be a problem. Backflow in blood during inflation of the cuff, and pulse oximetry malfunction when the cuff is inflated. These are some of the normal disadvantages of this automatic method. Now we are going to discuss the indications of non-invasive blood pressure monitoring. Every anesthetic agent, if we are using any anesthetic agent, it is the indication of using blood pressure, because most of them drops the blood pressure, except few like ketamine. So the technique and frequency of pressure determination will depends on patient's condition and type of surgical procedure. That will decide what blood pressure monitoring device we should use. Usually we use non-invasive blood pressure monitoring that records every 3 to 5 minutes in most of the cases. We should also know the contraindications of using non-invasive blood pressure monitoring. These are vascular abnormalities. If the patient is having dialysis, shunting, AV fistula on the limb, then we should not use non-invasive blood pressure monitoring on that limb or with intravenous lines. And then if there is any burn or no access, burn who have no accessible site for the blood pressure monitoring can be safely recorded by non-invasive blood pressure monitoring. Next, the important topic is factors that affecting the blood pressure reading. As we discussed, if the cuff is too small, it increases the blood pressure reading by 10 to 40 millimeter of mercury. If we use overclothing, then the blood pressure reading is also increased by 10 to 50 millimeter of mercury. If the back and feet are unsupported, then there would be a difference of 10 to 8 millimeter of mercury increased. If there is a stress, then increase would be of 5 to 40. Not taking rest between 3 to 5 minutes, then it increases 10 to 20 minutes. Patients taking, if the patient is talking, then the blood pressure is also raised by 10 to 15. If the patient has smoked, then 5 to 8. Full bladder 10 to 15. Cold temperature 5 to 8. Alcohol and caffeine also increases the blood pressure. Now, what are the timings of blood pressure monitoring? Blood pressure over clothing. We should not use on clothing. It should be on bare arm. Next, the smoking, tobacco smoking and cigarette smoking also increases. So refrain the smoking at least 30 minutes before having a blood pressure measurement. Likewise, if a patient is having alcohol or caffeine, it also increases. Soda, coffee, caffeine, all included caffeine. Then it is also advised that 30 minutes before this should be stopped. Likewise, if the patient is not resting, it is advised to have 3 to 5 minutes of rest before taking the blood pressure monitoring. Otherwise, it will be high 10 to 20 millimeter of mercury systolic. arm or back unsported. If these are unsported, then the blood pressure will be raised by 2 to 8 millimeter of mercury. Likewise, the temperature, if the patient is having uh, cold, and this will be higher than the expected blood pressure monitoring. If the patient is talking, it will also increase the blood pressure by 10 to 15 millimeter of mercury. Emotional state also increases. If the patient's bladder is full, it also increases the blood pressure. Now, our next topic is ECG. It is very important in daily routine, and especially in OT, in ICU, everywhere. ECG is very important. So we will discuss normals of ECG and slight basics of ECG. First of all, we should know how many electrodes an ECG can record. A normal ECG, standard ECG is having 12 lead ECG. It's having 6 chest leads that are directly applied on the chest, like V1, V2, V3, V4, V5, V6. And there are 4 limb leads, which gave the
Assalamu alaikum. Ehsan, I will just interrupt you for a second. Can you hear me?
Yes.
Actually, if you can explain a little bit, what will be difference if you are taking blood pressure in upper limb, okay, or you are recording the blood pressure in the lower limb.
Okay. If we take the blood pressure in the upper limb, it would be a little bit higher than the lower limb, because it's near to the aorta, so a higher pressure is recorded than in lower limb. Yes.
I'm not sure. I don't have the very clear concept about it. Maybe Amir bhai can put light on it. And another thing is that because there is a change in waveform as well. Okay, like this is something related to the vasculature of upper limb and lower limb as well. I'm not 100% sure. If
जी, over to Dr. Amir.
जी हसीब, आप करें कंटिन्यू.
Okay, sir. We will discuss it in end. So, discussing the ECG, we are having 12 lead ECG, standard ECG, 6 chest leads, and 4 limb leads. 4 limb leads include right arm, right leg, and left leg. In this, the right leg is the neutral one. The right leg, it's usually in black in color and in neutral one. Further, we will discuss where the ECG electrodes should be placed. The more important are the chest electrodes. These are V1 to V6. V1 should be placed in the 4th intercostal space right to the sternal edge. 4th intercostal space right to the sternal edge. And then V2, 4th intercostal space left to the sternal edge. These are easy one, but we should remember it is the 4th intercostal space we are putting the electrodes. Then we put the V4 directly. V4 we put in the 4th. Next one is the 5th intercostal space. We skip the V3 and directly put the V4 in mid clavicular line. Mid clavicular line is almost the same in which the nipple is present. We put the V4 in 5th intercostal space. We put the V3 in halfway between the V2 and V4. V2 and V4 halfway between V2 and V4 is this one is the V3. It could be on the rib, because 4th intercostal space V2 and 5th intercostal space V4. Next one is the V5. V5 is in the same 5th intercostal space, but in anterior axillary line. When the you should know the normal anatomy and the folds of axilla. Anterior axillary fold or anterior axillary line V5 is placed in that line. Then the V6, it is placed in the mid axillary line, middle of the axilla. Then there are also V7, V8, V9. These are used for posterior leads that should be beyond the scope of this talk. Then we come the Cm5 configuration. This is the most common three limb leads used for chest leads used for the determination of ECG pattern. In this, the one electrode is placed on right arm lead on the manubrium sterni, and the indifferent lead is placed on the left shoulder, and the left arm lead is placed on left ventricle in fifth intercostal space, like V5 position anterior axillary fold. This is advised because the heart is equally different from all these electrodes, and this gives the best interpretation using three leads. Otherwise, the number of leads we increase to 3 to 5, then the interpretation is made more reliable. Next, the important is the which leads are for which part of the are showing to the which part of the heart. Limb leads, first of all, discuss the limb leads. There are a pair of uh, 2, 3 AVF. This includes the inferior leads. One and AVL are including in the lateral leads, and then the AVR, it demonstrates the right side of the heart. 2, 3 AVF and 1 AVL. These are 1 AVL is the right lateral lead. It is the high lateral, and the 2, 3 AVF is the inferior leads, showing the inferior wall of the heart. AVR is normally demonstrating the right side of the heart. If we see on the ECG, always there is a pattern 1, 2, 3 AVR, AVL, AVF, then V1, V2, V3, V4, V5, V6, and lead 2 as a rhythm strip continuous. This is the pattern of a standard 12 lead ECG paper ECG. If we see what leads are showing the lateral leads, these are the 1 and AVL. These are showing the lateral leads of the heart. Other lateral leads are also V5, V6 are also the high lateral leads. And if we discuss high lateral, these are the higher side of the heart showing the 1 AVL. And V5, V6 are normally showing the lateral leads. Next, inferior portion is demonstrated by 2, 3 AVF. These are under the territory of inferior leads. We should remember this combination. Any finding in these at least two concordant leads, there should be a finding. Then we said that this is a significant finding on the ECG. If there is any finding in particular in any one lead, then this is not significant. At least two should be there to confirm any change on ECG in concordant leads, not in one is having a change in one and then next changes in two. Then this is not important because one correlates with AVL. If the any change is present in one and AVL, then that is important, or 2, 3 AVF or 2 AVF or 2, 3 or 3 or AVF. When discussing about the chest leads, V1 to V there is anterior leads V1 and V2. These are the anterior and also the right ventricle, showing the changes on the right ventricle. Then there come the anteroseptal V3, anteroseptal V4, and lateral V4, V5, V6 are the lateral leads. In combined from V1 to V4, we showed that these are the anterior leads, and V5 to V6 are the lateral leads. So any change in two concordant leads must be important one. So the next one is the waves of the normal ECG. A normal ECG is having a P wave. It is a normal upstroke and a normal downstroke. Then there is a PR segment there which ends after the P and before the starting of the R. This is the PR segment. And there is important is the PR interval. It is from the start of the P to the start of the R. Then there comes the Q wave. The first downward deflection is the Q wave. Then upstroke is the R wave, and the downstroke is the second downstroke is the S wave. We call it is a 2RS complex. Sometimes we find only Q wave is present. Sometimes we find that the Q and R is present. Sometimes we find that Q, R, and S is present. Sometimes all three are present. But it is not be a must that all three should be present in every lead. Then important thing is the ST segment. It is important in ST segment elevation or ST segment depression. Then there is a QT interval from the start of the Q to the end of the T is the QT interval. If we discuss the importance of P wave, it shows atrial depolarization. And if we normally, if we generally see the P wave, all P wave represent the atria. And QRS represent the ventricles. If we see in detail, the QRS showing the ventricular depolarization. The atrial depolarization is having so small voltage that it is buried under the QRS complex. And the atrial repolarization is demonstrated by a T wave. So in general, P wave, atria are represented by P wave and ventricles are represented by QRS complexes. We find the findings of ventricle abnormalities majorly in QRS. Interpreting the ECGs. First of all, we should document the name of the person, age, time, and date, because this must be important to relate the events on the ECG, that at what time these findings are present and correlate further for after the interval serial ECGs. That we will know the pattern of the changing ECG. Then any previous or subsequent ECG is more important, because we should have to know the previous status of the heart, that what previous changes were present on ECG and what are the new changes that the person is having. Then the important is the calibration. We will discuss further the rate, rhythm, axis, and elements of the tracing in each lead. First of all, we should all know that what is the standard calibration of the ECG. The standard calibration is having the height of 10 millimeter. If the paper is not calibrated to 10 millimeter, it is not the standard ECG. And the paper speed should be 25 millimeter per second. This is the normal speed, paper speed. If we increase the speed or decrease the speed, the tracing will be different. So for normal interpretation of ECG, we should know that the paper settings and ECG machine settings should be on 10 millimeter of height and speed of 25 millimeter per second. Next is the information on the ECG, as some information is already calculated by machine, and sometimes it is right and sometimes it's not related to the patient condition. because it relates to the pattern that is drawn on the ECG paper. It can be due to some artifact. If the artifact is showing some vibrations, it can show atrial fibrillation or this and that. But we should know that what are the artifacts and what are the original ECG findings. Likewise, in this ECG, the initial vibrations, these are the artifacts. Like this one, these are the artifacts present on the ECG. What we should know for the ECG are the all limb leads are correctly placed, because in for example a new person who do not know how to apply the limb leads, limb lead reversal can be results in many changes on the ECG. We should discuss further like limb leads. In limb leads, what are the limb leads? One, two, three, 1, 2, 3, AVR, AVL, AVF. But there are the four leads which we apply on the four arms respectively. Right arm, left arm, right leg or neutral, and left leg. So if we interchange right arm with left arm or left arm with right arm, then the AVR will go to positive. Likewise, the lead one will go to negative. In normal ECG, AVR should always be in negative position, and lead one is always in positive position. Discuss on ECG. This is the AVR. It is interpreting the heart from the right side. As we all know, our heart is on the left side. And if I roughly draw a diagram of the heart, this AVR is interpreting from the right side, and the heart is majorly on the left side. So all the ECG tracings should be on the negative side in AVR. In normal AVR, if we see a normal ECG like this one, all the deflections should be on the negative side in AVR lead. It shows that the ECG is done with placing the correct electrodes. This is QRS is major downward deflection, T wave is downward, P wave is downward. Like T wave, P wave, QRS, all are downward in AVR. If we found that there is a positive in AVR, then there are two possibilities. If the person who done the ECG places the wrong leads, or the heart is on the right side, like dextrocardia. In dextrocardia, you know that the heart is rotated on the right side. So in dextrocardia, we could find the AVR is having positive deflections, because AVR is interpreting from the right side, and the leads are also showing to positive deflection. This is the measure on the limb lead placement. And about the chest leads, if we improperly place the chest leads, then we came out to be poor R wave progression. I demonstrate this on the diagram at which we discuss the chest leads. This is the normal positioning of leads. So if we place the leads too far from the heart, like from the fifth intercostal space is the normal, and we placed in the sixth intercostal space, then there is heart far away from the sixth intercostal space, we came out to be poor R waves on the ECG. So there are multiple causes of poor R wave progression. We will discuss that later, but we could have poor R wave because of poor lead positioning. R wave are formed too small and poor R wave progression. By definition, what is poor R wave progression? Let's also discuss that. Normally, equiphasic means the positive and negative deflection are equal. When the positive and negative deflection are equal, it will be called as equiphasic. In V3 and V shore, it should be equiphasic, either in V3 or V4. If it is delayed, then the V3 that we found that equiphasic phase leads in V5 or V6, then this is the example of poor R wave progression. In this ECG, there is no poor R wave progression. Poor R wave, this upward is the R wave. It normally increases in size from V1 to V6. In V3 and V4, it equals the S wave, and tallest as the in the V6 and minimum in the V1. R wave increasing in pattern as we go from the V1 to V6. This is the normal transformation of the R. Other problems with the ECG, let's discuss like this one. This is not the PVC. This is the artifact. The patient or electrode is misplaced during this beat, and the patient or the patient moves, then this type of tracing is present. This is the artifact, not the, because we how could we confirm it? Because in lead 2 this is present, and lead 3 it is correctly over. In this position a cracked beat is present, and likewise in lead 2 there is crack. In other leads also there is no abnormality at that position. So that could be a artifact because of lead 1 or lead 3 are misplaced, or some vibration must be there, so the tracing is distorted. Other are the muscular tremors. If the patient is shivering, then this type of tracing is present. Like in a patient of Parkinson disease, we could not find a bill, a completely fine, we could not trace. We always get a shivering ECG. Then electrical interference. Most of the time we came that there is a blackish tinge on the ECG, and these are due to the electrical interference. It can be due to a socket, any magnetic thing in the pocket or metallic thing, or patient is touching to any metallic object, then this type of tracing can be present. These are not the abnormalities, but we should apply a proper gel to overcome this type of electrical interference or remove any electrical interference in the field. Then we came about the heart rate. Heart rate is calculated by a simple formula: number of big blocks divided by 300 divided by number of big blocks. This is the normal formula. For example, if we found there are 4 R waves in let's discuss on ECG. Like this. How could we calculate the rate? Uh, we could have to count the rate from the big blocks. One big block, 2, 3, 4, and 5. There are 5 big blocks, so 300 divided by 5 would be 60. 60 would be the rate of this rhythm, ECG. And some of the common rates we should know that if there is one large block coming, the rate would be 300. 2 large blocks, 150. 3 large blocks, usually our heart rate would be near to the 100, less than 100 or more than 100. We can start counting from the three. The three large boxes are there, then the rate would be equal to 100. Four large boxes 75, five large boxes 60, likewise 50, 43, 38, 33. And then this is for just practice, but can we count the large box from this ECG? For easy interpretation, we should have to locate the R wave that is falling exactly on the large line. If the rhythm is regular, this is for regular rhythm. In gross appearance, the rhythm appears to be regular, so we find that R wave that is falling exactly on our line, so our counting could be made easily. One large block, two large block, and 0.5, 2.5 large block is there. So 300 divided by 2.5. So at like this, we can find 175 could be the heart rate of this ECG. Next come the rhythm. So there could be some topics we normally came up with the ECG. Topics could be multifocal or unifocal. If it is unifocal, then same type of PVCs are present. In PVC, there is a broadening of QRS complex. This is the normal QRS complex. This is narrow, always narrow. And we are seeing that this is the broadening of QRS complex following inverted T wave. This is a PVC. And this is a multifocal PVC. The other focus is downward broadening of the QRS followed by upward broadening. Next is the PR interval. This is important in AV blocks. The normal PR interval is 2 to 5, 3 to 5 small blocks is the normal PR interval. We are finding that in this ECG, this is the P wave and this is the R wave. It is from the start of the P wave to the end start of the R wave. It is more than more than 5 blocks. Then this is the prolonged PR interval. So this is the ECG of prolonged PR interval. It is the first degree AV block. We will discuss further what is the first degree, second degree, and third degree. But this is the example of prolonged PR interval. Then there is an important finding like there is a delta in this ECG. A delta wave is showing. This is the PR interval is shortened. If there is a short PR interval, then this is like this. The slurring of the upstroke. The upstroke, normal upstroke is like this, but if this is slurred like this, then this is short PR interval. P wave is there and R wave is there. So this came with this is the delta wave, and it came in WPW, Wolf Parkinson White syndrome. This is a finding of that. So in normal, the short PR interval is mostly in delta wave and WPW syndrome, or it can be in other ECGs. Then this is the first degree AV block in general. This is the PR interval is prolonged. Fixed prolonged PR interval. This is the finding of the first degree AV block. In second degree AV block, Ecgs phenomena, PR interval gradually increases. Like this is the PR interval, this, then there is a drop beat. If one QRS after a P wave, QRS is dropped. Like this. PR interval gradually increasing and then there is no R wave, there is a missed beat. This is the example of Wenckebach first degree or second degree Wenckebach
अच्छा
type 1.
राजमरीता की मसला बनया भाई
Then they come the second degree type 2. The second degree, there is PR interval is fixed. PR interval is fixed, but there is a missed beat after every 1 or 2. Like this PR interval, P wave is there, R wave, QRS complex is there, P wave is there, but no QRS complex is there. Then again, P wave is there, QRS is there, P wave is there, QRS is there, P wave, but no QRS is there. In this, there is fixed PR interval, but there is missed beat. This is the recognition of second degree type 2. Then there is came the third degree AV block. In third degree AV block, there is no association between atria and ventricles. Atria are beating independently but fixed, and ventricles are beating independently and also fixed at fixed rate. So P, as we know that P wave is representing atria and QRS is representing ventricles, then the PP interval is always fixed and RR interval is always fixed in third degree block, but there is no link between the P and R. ATR contracting independently, ventricles are beating independently. So this is the complete AV dissociation. Atria to ventricle, there is no linking. Then the important thing is the Q wave. Q wave normally shows pathological, but when we call this pathological, let's discuss deeper than the two small squares. If it is deeper than the two small squares, then it is pathological. Or wider than one small square. Wider than one small square. In if it is less than two small square, it is not significant. And there are multiple criteria to label pathological Q waves. If it is more than the 2/3 of the QRS complex, then it is always pathological. If it is small than the QRS complex, then it is normal. When when Q waves are present, it is present in old anti-war MIs. When there is old STEMI, then then after some time the Q waves would be present, and that will present lifelong. Like this, initially there would be some ST elevations there, and then Q wave is present, and this is the Q wave in V1 and V2. There is obvious Q wave. This is an example of septal MI. We also are finding a T wave inversion, deep T wave inversion, and also an example of ischemic changes. Then if we know the want to know the height of the QRS, it will demonstrate the left ventricular volume. Like if there is hypertrophy of the left ventricle, QRS height is large. Then the QRS.
यार मुझे भी दिला दे, मैं साथ साथ लिखूंगी. तो यार आज तुम हर चीज में नेगेटिव क्या क्यों आलियतियां करिए, तो हम क्यों नहीं, तुम ये कहो.
If the QRS width, we normal QRS is less than 3 small squares. If it is greater than 3 small squares, then there is wide QRS. And the wide QRS is always pathological, like it is present in some, if we find a wide QRS, there either there may be right bundle branch block or left bundle branch block. Let's discuss right and left bundle branch blocks. First, we will see the V1. If there is more than 3 small blocks, there is a wide QRS complex. And in our LB3, there is downward deflection, major downward deflection with wide QRS complex. This is the simplest way to identify LB3. Just see V1. If there is broadening of the QRS complex, then there is bundle branch block is there. If the major deflection is downward in V1, then left bundle branch block is there. If in V1 there is next slide, like if there is in V1 there is the major upstroke is there with wide QRS complex, then this is RB3, right bundle branch block. It's very easy to identify. This is the mnemonic related to William Marrow, but it's more easy that if we include just if there is wide QRS is present, there is bundle branch block. And if the complex is V1 is having negative deflection, it's LB3. And if V1 is having positive deflection, it's RB3. Like, what's this pattern? This pattern, just see V1 with wide QRS complex. Wide QRS complex is present in every lead. If there is present in one lead, it must be present in every lead. So, and major deflection is downward. This is the LB3. If we see the clinical significance of LB3, 75% of the LB3 is pathological. It's related to ischemic changes. Next, if we saw this ECG, we just found that in V1 there is broad QRS complex with major positive deflection. This is RB3. RB3 is less pathological. It's 25% pathological and 75% is present in normal healthy persons, like no ischemic event. Then came the myocardial infarction within hours. The first finding we get on the ECG is T wave. It is peaked T wave, but not with narrow height. It's with a flattened height. Then came the ST segment elevation came to rise. We will see in this like this. There is ST segment elevation, S and T. There is elevation of S and T. This is the example of ST segment elevation. In the within 24 hours, T wave inversion may or may not be present. ST segment elevation begins to resolve, and after resolution of ST segment elevation, Q waves would be present. Within a few days, pathological Q waves are formed. Next important is atrial fibrillation. For atrial fibrillation, just remember two things by definition: absent or bizarre P wave. It is not necessary that P wave must be absent. It can be bizarre in atrial fibrillation. In atrial fibrillation, atria is fibrillating like this. It's not contracting regularly. There are multiple causes of atrial fibrillation. We will discuss later. But by definition, first thing we should interpret on ECG is absent or bizarre P wave. The next thing is irregular rhythm. If there is irregular rhythm with absent or bizarre P wave, there is atrial fibrillation. In blocks, there are always regularly irregular. So we differentiate grossly blocks from atrial fibrillation by if the pattern is if the irregular rhythm is regular, then it is block, and if it is irregularly irregular, then it's atrial fibrillation, more likely to be atrial fibrillation. Like this is the fibrillatory P waves. This is P wave is present, but this is atrial fibrillation with fibrillation. In this ECG, P wave, a normal P wave is present. This is not the atrial fibrillation. The above one is the atrial fibrillation. And the other finding, we are finding that the RR interval is irregular, irregularly irregular. There is no fixed pattern. Like this ECG, this is also an example of atrial fibrillation. RR interval irregular, and P waves, no discrete normal P wave. Then came the atrial flutter. Atrial flutter is almost clinically equal to atrial fibrillation. Treatment is always same, but we found that there is sawtooth appearance. Atria is fluttering, like multiple beats are present, multiple P waves are present before a QRS complex. QRS complex is reflecting the ventricle contraction, and P wave is reflecting the atrial contraction. So atria is contracting multiple times before a ventricle is going to contract. These are the examples of atrial fibrillation. Then there came the ventricular tachycardia. In ventricular tachycardia, always there is broad QRS, because QRS is showing the ventricles. If there is broad QRS and tachycardia is there, there is that leads towards the ventricular tachycardia or VT. But if pre-existing LB3 or RB3 is present, then it is difficult to interpret that either the widening of QRS is due to ventricular tachycardia or LB3 or RB3. Then came the sinus. What is sinus rhythm? We normally call NSR, normal sinus rhythm. What is normal sinus rhythm? The normal sinus rhythm is if the P wave is present before QRS, then this is normal sinus rhythm, and it is generating from SA node. Every P wave followed by QRS complex, normal P wave, then it is the normal sinus rhythm. If P wave is absent, then it is not sinus rhythm. So that would be the end of basics of ECG. Hope you would find many to learn. Thank you.
Thank you, Haseeb. Good presentation. डिटेल से आपने कर दिया इसको कवर. जी हसीब, मेरी आवाज आ रही है आपको?
जी सर.
नहीं, ठीक है. मेरे ख्याल में टाइम 11 से ऊपर हो गया.
जी सर.
जबरदस्त प्रेजेंटेशन. इंशाल्लाह फिर नेक्स्ट फ्राइडे को अपना टॉपिक अब आप कल परसों में ही फाइनल करके ग्रुप में शेयर कर देना कि नेक्स्ट फ्राइडे कौन सा टॉपिक होगा.
ओके सर.
थैंक यू सो मच. अल्लाह हाफिज.